It's Wednesday evening, and I'd like to welcome you all to the SAPA webinar. My name is Mignon, and Beira Rousseau has organized this webinar. We've got a very exciting evening ahead. We have 3 topics, and I'm going to let Beira introduce each person. We have got quite a lot of you already, and that's really exciting. So we've got 128 people, which is fantastic. I'm just going to ask that you all mute your microphones, and at the end of each presentation we're going to be taking questions, and we will ask you to put your questions in the format of the chat so that you actually write your questions down. We seem to be running 2 webinars with the same address, so if anybody is struggling to get in, if you can just write in the chat group. And with that, I'm going to hand over to Beira Rousseau. Thank you, Beira.
Good afternoon, everybody. Can you guys hear me?
Yes.
Right, so we're going to start with Dr. Shamiel Salie, who is Director of the Intensive Care Unit at Red Cross, and he's going to talk to us a bit about critical care treatment of COVID children, and specifically how to do safe non-invasive ventilation. So let's get over to Shamiel. And then I just want to remind you to mute your speakers.
Thank you, Shamiel. You just need to mute your microphone.
Hi, Mignon, can you hear me?
We can hear you indeed, and I'm just going to ask you to share your screen, Shamiel. Great.
Hi, Mignon. Is that clear enough?
Perfect.
Can you see my presentation?
Can see your presentation? Great.
Okay. So good evening, everybody. Thanks, Beira. My name is Shamiel Salie. You know, it's been a real tough 6 weeks, and I think I'm really suffering from a bit of COVID encephalopathy at the moment. It's been 6 weeks of planning, thinking it through, being bombarded by information from abroad, WhatsApp groups, and really just to talk through our approach of how we're going to manage kids with suspected COVID in our ICU. I mean, I'm fully aware that we all work in areas with different resources, so this is really about what we're doing in Cape Town, and hopefully you'll be able to find something that's applicable to your settings. You know, there's been a big debate about, or big talk about, whether non-invasive type ventilation is appropriate in COVID, in pediatrics, and coming from the adults' recommendations that early intubation is preferable, that adults with non-invasive type ventilation potentially do worse. The adults were recommending early intubation, but we'll talk through some of our thoughts as to why we don't think that's appropriate in pediatrics. So maybe just to, let me just do that. And maybe some background information. I'm sure you people have read this information, but this has been around for a while, and looking at China, looking at where it all started, looking at the numbers of children infected from the Chinese CDC, you know, they are looking at 72,000 cases. Only 1% of cases, confirmed COVID cases, were in children under 10 years of age. And looking at the epicenter in Wuhan, where they tested almost sort of 1,400 children over roughly a 4-week period, they only found about 12% of cases. But how sick were these kids? So, you know, there were a fair number of children that were asymptomatic, that were infected. Only 3 of these children were admitted to ICU and needed invasive ventilation. And 1 child died from intussusception with multi-organ failure. So very few children seem to be affected. Looking at the age groups of these children, most of them were older, median age group of about almost 7. Looking at most of our kids that we're going to expect to get with our coming respiratory viral season, sort of the under 1-year-olds, there were only about 18% of children under 1 affected. Nearly 16% of children had asymptomatic COVID infections. Looking at signs and symptoms, not surprising that coughs, fevers were more common. We've recently diagnosed a kid with diarrhea with gastroenteritis. There's been an alert from international societies about a Kawasaki-like shock type syndrome, which is going to need to be added to this. But presentations can be quite diverse. In terms of how sick these children were, these Chinese kids, 30% of them were tachypneic, and only 4 of them had low SATs, so not very sick. Some data from the States where they tested nearly 150,000 people, only 1.7% of children had confirmed COVID. I find this diagram quite illustrative. If you look at number of cases and age groups, black is the non-hospitalized kids, and you can see that the older children, the teens, predominantly infected, but most of them not hospitalized. If you look at the younger kids, sort of the under 5-year-olds, a fair proportion of them not hospitalized. The darker blue group is the proportion of kids that are ending up in hospital, and the light blue is the small percentage of children that would need. So a lot of the concern about COVID in pediatrics is about protecting healthcare workers, and a lot of this is about limiting the amount of aerosol generation from common procedures, from NEBs, non-invasive type ventilation, from suctioning, from intubation and ventilation. So the adults have really sort of made us think, if they're recommending early intubation, is that something that we can do realistically? If I think about our ICU during RSV season, then we're running full 22 beds. Most of those kids are intubated, ventilated, but a large cohort of children are in the wards on CPAP in district hospitals and high flow. And if we can't use non-invasive type ventilation, we're not going to have enough hospital beds to ventilate these kids. But I'll go through some of the practicalities and some of the thoughts about why we think it's why it should be feasible to do non-invasive ventilatory support in children. So just to remind you, I think NIV, CPAP, high flow has become so entrenched in caring for children with bronchiolitis with severe respiratory distress. If you come into hospital with a sore toe and you're breathing fast, you're likely to end up on high flow or CPAP as well. So, in terms of CPAP, high flow, it reduces inspiratory, expiratory work of breathing. It improves oxygenation, and reduces shunts, reduces ventilation, perfusion matching. And over the years, we've intubated a far fewer children than we have previously before we've used CPAP and high flows. So some of the concerns with high flows are, and I'm sure you guys are familiar with these prongs, is that the high flow prongs are quite small, and so sometimes flows can be used up to 50 to 60 liters. And smallish prongs, high flows, the risk of aerosolization is real. Whereas if you're using CPAP, we tend to be using larger type prongs with more of a sealer on the nostril. There's also inspiratory and expiratory limbs, so children are exhaling through the ventilator circuit, so there isn't as much contamination of the room. All of this is relative, how much there is going to be. So if you are going to be using non-invasive type ventilation, then you ideally should be using it in a negative pressure room. But we all know that they're very few and far between. Looking at some data from a group in Hong Kong, and where they looked at air dispersion during high flow, nasal cannula versus CPAP. They had a fancy setup with a high digital camera. They had a model that when the model exhaled, there was smoke that was coming out, and they had a laser which captured the smoke and showed you where all the exhaled gases went. And looking at children, looking at this model on high flow, looking at, if we looked at high flow at 10 liters, 30 liters, 60 liters, and we're looking at this model with where they could change the compliance of the lungs, they could change tidal volumes and respiratory rates. So they tried to model normal lungs, mild lung injury, and severe lung injury. Hi.
Shamiel, do you mind just unmute? Yeah, go for it. Okay.
I'm not sure at which point you lost me, Mignon. I just realized that, was it on the slide? Was it on this slide that you lost me? Yes.
Just as we came onto that one.
All right. So talking about flows, and if you're looking at increasing flows, what this diagram is showing is that the higher the flows you're using, the more dispersion you're getting. This was in a negative pressure room, so you could see a lot of the flows were directed upwards. Comparing this to CPAP, and once again, looking at CPAP at 20 centimeters, 15 centimeters, 10 and 5 centimeters, you had much less spread when you were using lower CPAP. So ideally, if you're going to be using non-invasive ventilation, aerosolizing, negative pressure rooms, just to try and contain the COVID in the air. However, if we're not going to have a negative pressure room available, what we're thinking about is probably cohorting a few children together and staff in full PPE and caring for those kids. Interestingly, PPE is also changing, from full N95 mask. People are saying with the limited availability of PPE, even just a surgical mask might do if you're wearing that underneath the face shield. Some of the modifications that we've done also to try and limit the amount of aerosolization is to think about putting on a filter on the expiratory limb of our bubble CPAP. So all expired gases are filtered, potentially covering children with a plastic sheet. Some people are manufacturing Perspex hoods, but we're staying away from those. Looking at the ESPNI guidelines for managing kids, and they do it quite nicely in terms of kids with potentially COVID. So they're recommending kids that are not severely infected to preferentially use CPAP, BiPAP, and high flow if that's not available. But, if you are using non-invasive type ventilation, you need to be carefully monitoring these kids. And what we're also noticing is that people are so petrified of caring for kids with COVID that the basic nursing care doesn't happen. So, is the nose patent? Is the prongs fitting nicely? You're actually delivering good quality and effective CPAP is very essential to ensure. There was a talk previously about intubation, and I can't really go into all of this, but really if you're intubating children, needing to ventilate them, using cuff tubes, making sure that you're using lung protective ventilatory type strategies, you need to be thinking about not necessarily targeting normal sats, targeting lower sats. We sometimes go down to 85, 92 saturations. Potentially paralyzing children if you're struggling to ventilate them. Prone ventilation definitely helps oxygenation. manipulating PEEP. Inhaled nitric oxide has been touted as potential good intervention in children with severe hypoxic lung disease. We've used high frequency oscillation. We've used a good infect in 2 children that came in as a PUI. One turned out to have rhinovirus and the other kid ended up having severe sort of staph sepsis. But children with severe lung disease, we've oscillated kids quite effectively. And then if you have ECMO available, that's a final option. Once again, if you're needing to bag kids, and interestingly, when we needed to intubate these kids with severe lung disease, trying to do it under the plastic sheet, they both desaturated quite dramatically and needed to be bagged. So even though the guidelines are saying try not to bag, inevitably when kids have stiff lungs, you would need to oxygenate them. We're also using filters in our expiratory limb on our ventilators to trap expired gases. And on the oscillator circuits, we've connected a sort of a hose pipe with a filter to trap the gases and a water trap. So really, you know, what we probably need to realize is that there's relatively few children that we're going to be encountering with COVID-19 infection. However, we're just about entering our respiratory viral season, and we're going to have many kids with RSV, influenzas, and it's going to be very difficult to know upfront. At the moment, it's taking us 4 or 5 days to get a COVID result. So streaming these kids and caring for them is going to be quite difficult. We're definitely going to continue using CPAP high flow. It's going to end up cohorting kids, but then importantly to look after staff, then PPE, full PPE is going to be essential. And then I think most importantly, we need to be keeping an open mind. There's a flood of information out there. The current thing that I'm onto at the moment is epistemic humility, is that, you know, we all think we know it all, but knowledge is provisional and incomplete. And we need to think about revising what we know in light of new evidence as it becomes available. Thank you very much.
Thank you, Shamiel. If you can post some questions on the chat group for Shamiel. I see there's the first one. What is the smallest cuffed ET tube available?
So we've got a size 3 endotracheal tube, 3 cuffed, which equates to about a 3.5 ET tube.
And there's a question, Shamiel, what do you mean with epistemic humility?
It's knowing your limits, you know. It's about keeping an open mind. It's about what we think we know today. If something else comes to light tomorrow, you know, being open enough to change what you think you know, and to constantly look at the literature that's out there that's being developed. And in an epidemic like COVID, where we don't know all the answers, where, you know, for example, this Kawasaki-like syndrome, it comes out of the blue, you know. So to keep an open mind as to when we're treating children, as to consider new treatments. Yeah.
Thank you very much, Shamiel. I think we need to move on, but there's a question from the group if we can share the pictures with the filters on.
Happy to give you the talk, Vera.
Right, then I will put that and send it through to the email addresses that we've been using to circulate this. Thank you very much, Shamiel.
Yes.
I want to welcome our next speaker, Dr. Graham Howarth, very well known to us from the Medical Protection Society, leading the African group. And I want him to speak to us about medical legal issues that's been arising around the COVID pandemic. Graham, thank you very much for joining us.
Well, thank you very much for the opportunity. I certainly hope you can hear me. Can you hear me all right?
Yes.
Yeah.
Excellent,
Okay.
good. Well, thank you for the opportunity to speak to you. It really is, Shamiel, if he doesn't mind, I'm going to pinch that term epistemic humility from him. I really like that. But I mean, it really is an exciting time intellectually particularly in South Africa, although very worrying. I'm speaking to you at the moment from the UK, and you'll appreciate that we're seeing people dying at just short of 1,000 a day at the moment, to give you an idea of where things can go. And I think South Africa is still managing to keep under 100. Now, from a medical legal point of view, I'd really like to open myself up to questions, but the questions have been so difficult that we've been receiving that to try and answer them during the course of a webinar or live could be quite overwhelming, to be quite honest. It's interesting if you look at what's happened, and to use economic approach to things, I'll talk a little bit about supply and demand. It's interesting to see in South Africa what you're doing about supply. I know that you've brought in Cuban doctors, although it does appear that there's a degree of controversy in that. I believe that they're looking at expediting the promotion of medical students. You're looking at the use of retired doctors and nursing staff, all on the supply side, to try and make sure that you have enough resources available when the surge occurs. I was also interested to read about the national ventilator program and see how they're hoping to have 1,500 new ventilators available by the end of next month, and then 10,000 a month later. My understanding is that there'll be CPAP ventilators, and I was interested to hear, I was speaking to some of my colleagues here today in Bradford, and they're anaesthetists, and they were saying that the adult patients that they're currently seeing at the Bradford Royal Infirmary are doing better when they're ventilated with CPAP masks as opposed to intubation. So it's just interesting to see different points of view. If you look at the demand side, then South Africa has been credited with incredible success with respect to the lockdown. And I know the President spoke to you on the 15th of March, and then he announced the lockdown a couple of weeks later. And then you went into a 3-week period of lockdown that's now been extended by another 2 weeks. And one of the things that's really interesting to us from a medical legal point of view is the way that South Africa is being managed from an executive point of view at the moment. To a large extent, you are being managed under the current law and by executive regulations. If you go onto the government website, you'll see that there are a whole lot of regulations being put out fairly regularly. And we are waiting for the new regulations now that will dictate how South Africa will be governed as from Friday, being the 1st of May. Those regulations are very important and interesting. For example, if you looked at the regulations when they first went up on about the 18th of March, there was an interesting regulation referred to as Regulation 11E, which interested us in particular because it gave an indemnity to the security forces if they used excessive force to enforce any subsequent lockdown. Now, the reason it was interesting to us was that someone's seeking indemnity, but it was equally interesting that a day or so later that regulation was withdrawn because it was clearly against what would be constitutionally acceptable in South Africa. Turning to COVID itself, it's been interesting to me how our queries and requests have been coming through. We open probably about 15 to 16 files a day, and most of them at the moment are either advice files or alternatively something to do with HPCSA complaints. And they've been coming through in relatively clear groups. Initially, there was an awful lot to do with telemedicine. As you can imagine, people were worried about COVID. They wanted to see patients, but they were concerned about seeing them face to face. They were interested in telemedicine. For those of you who follow what the HPCSA is doing, they have their booklet number 10 on telemedicine, which is extremely restrictive. And then they changed their restrictions quite substantially to free up telemedicine to a certain extent. But the one thing that they didn't do was free up telemedicine with respect to the first consultation. And that made it then very difficult for doctors and other healthcare professionals if they couldn't use telemedicine if they hadn't seen the patient previously. We had to develop a workaround for that, if you will, and we said that the Health Professions Council is primarily interested in the best interest of patients. So if you could motivate it under the auspices of acting in a patient's best interests, then you may be able to overcome the issues with respect to not having seen the patient previously. We did 2 webinars on the subject, and interestingly, during the course of the second webinar when we were speaking, the HPCSA changed their regulations such that one could do telemedicine consultations, or telehealth as they like to refer it, including seeing patients for the first time. That was interesting to us. Then, of course, followed a whole host of queries about whether or not you could do telemedicine under certain circumstances, and we did indeed have a whole host of queries from pediatricians with respect to that. The next area that seemed to perk up people's interest was working beyond your area of comfort or outside of your speciality. Now, interestingly, the restrictions of specialist practice first came to my notice about 7 or 8 years ago when I was approached by a pediatrician who'd run into trouble with the HPCSA. And his problem was that when he saw mothers of sick children on occasions, would give them repeat prescriptions for antidepressants. And there was a complaint to the Health Professions Council about that. And in essence, if you are registered as a specialist, then strictly speaking, you should only work in your area of speciality. And clearly, a pediatrician prescribing antidepressants to the mother of a sick child, albeit that she'd already been diagnosed with depression, was working out with your area of speciality, and hence the problems that he ran into. But be that as it may, you can imagine that if there is a surge, then people will be working out of their area of speciality. And the Health Professions Council, to a certain extent, has relaxed those requirements. I mean, I've got a colleague at the moment, again, who I was speaking to the other day, who's a dentist. He's working in one of the large ICUs in London. And his role there really is part of a turning team. And they go around and turn patients in the ICUs, because apparently when the patients are lying on their stomachs, they seem to be ventilated better, and that's adult patients. And it takes 20 minutes to half an hour for 8 people to turn a patient, and all they do is go from one bed to the next, turning people. So, you know, you can act in different areas, and we've had quite a lot of requests along those lines. The next area goes around patients becoming COVID positive as a result of going to see a doctor, and what should doctors be doing to prevent that. And, you know, we point out the difficulties of proving that sort of thing, that you have indeed become positive as a result of a visit to a particular doctor or a hospital, but obviously one has to warn patients. The other issue that is important at the moment is the issue of indemnity. If you work in the state, then the state is responsible for your acts or omissions. So if you are sued, then the state basically covers you under the Treasury regulations. Excuse me, that's not the case if you work obviously in a private hospital, then you get sued in your personal capacity. The problem at the moment is there's an anticipation that state patients may be managed in private hospitals, and the question then goes around indemnity issues. Now, with the notable exception of South Africa, all other countries in the world that we service, the indemnity follows the patient. So the state indemnifies the state patient managed in a private facility. But that's not the case in South Africa. And then moving on really in ending onto the last area is probably something you have a lot more experience than many of our colleagues do, is on withholding and withdrawing treatment. One of the problems that's going to occur, and we have experience here from the UK, is with the limited intensive care beds, then patients are obviously not admitted into intensive care. And then the next problem is withdrawal of treatment. And we're not talking about withdrawal of treatment where the patient has already been declared as brain dead or physiologically dead, but or indeed where there's even futile treatment. There are cases here where there are patients that have been put onto ventilators and been removed from ventilators where they're just clearly not getting better. And there's a patient with a better prognosis who requires the ventilator. Now, we had a big seminar here in the UK recently, and they have a court of protection here, which makes things a little bit easier, and we had court of protection lawyers involved. But as a result of that interesting conversation that followed, we'll be holding a webinar tonight on withholding and withdrawing treatment. And one of the really interesting things is, as us as doctors, when we are involved in these decisions, we see them either as ethical decisions or medical decisions. Now, to an extent in South Africa, probably the best guideline at the moment is from the Critical Care Society of South Africa. They have a consensus statement out that was published in the South African Medical Journal of July last year. The problem with the consensus statement is if you look at all the authors, they're all doctors, which is fine, but there's no lawyers there. And if you withdraw or withhold treatment, definitely in an adult, then there are legal ramifications. It's not impossible that a charge of culpable homicide could follow if you do it under the wrong circumstances. And we're very keen that national guidelines should be available on the withdrawing and withholding of treatment. And I think I'll probably end my presentation there if it's all right with you.
Thank you, Graham. I wonder if you guys can post some questions on the chat box for Graham, specifically in terms of medical legal questions. Maybe I can kick off just with one question that I've been wondering working in the ICU. If I am faced with a child needing CPR and I have to don off, there's going to be don off on my PPE, there's going to be a time delay in getting to the child. What is the legal ramifications in a situation like that?
Well, I think, you know, and let's move beyond that, because there's going to be a whole host of decisions that one is going to have to make. Maybe some not as acute as that, or not as serious as that, and some possibly more serious than that. Basically, you'll be judged against what would a reasonable doctor do under similar circumstances. That's the one thing. And the second thing is that it cannot be expected of you to place yourself at an unreasonable risk. So it's a little bit like if you're walking past a neighbor's 1-foot pond and you see a child fall into the pond, then you probably are morally obliged to step across the fence and go and save that child. If, on the other hand, you're next to a raging river and you see a child being swept away in that raging river, you don't have a moral obligation to jump into the river and put your life at almost definite risk. So it's a way up, I'm afraid, at the end of the day. You've got to weigh up the advantages and the disadvantages. What are the alternatives? And maybe this is a poor example because it is so acute, but often what we get caught up in is binary choices. We think there is only one thing or another thing that we can do. And we've got to start thinking, are there third options? Is there something else that you can do in the meantime? I mean, I don't know enough about resuscitation anymore. You know, is there a role for an ammu bag in the meantime? Are there other things that can be done to support the child while you don up? So I think, you know, the short answer to your question is try and think broadly, try and push away from that binary choice, yes or no. Is there something in between? And secondly, ask yourself, what would a reasonable doctor do under similar circumstances? Because that's against whom you would be judged.
Thank you, Graham. I see there's questions on how the people can join your medical legal seminar, webinar.
I think if you go onto our website, hopefully there'll be something on there. I suspect as well, I've heard that there's a large, either South African Private Practitioners Forum webinar tonight or a Discovery webinar as well. And what we tend to do if the webinars are well attended, and we tend to have about 1,000 attendees, we tend to repeat them as well. So if it's not tonight, and if you are an MPS member, then strictly speaking, you should have received an invitation. And the other thing to do is to go onto Twitter. I know the Twitter account is advertising it as well.
Okay, Graham, there's also a question from Michelle Meyering. What is the medical legal issues of withdrawing and withholding in children?
Well, I think you could write a PhD thesis on that. I think they're no different really at the end of the day to an adult, or maybe an adult without decision-making capacity, depending on the age of the child. You know, the area to start for me, there was an article as well by, is it Dania Ballot from the University of Witwatersrand, wrote an article in the South African Journal of Bioethics and Law. Within the last year or so, you can go onto their website and search for it. She has information there on children specifically. Look at the consensus statement of the South African Critical Care Society, and then also read booklet number 7 of the Health Professions Council, which is available freely on their website. And they all give you, let's call it ethical approaches, not necessarily answering the legal questions, unfortunately.
Thank you, Graham. And there's a question from Kelly Russell. When you refer to withholding care, would it mean that you would withhold ICU care if the patient is COVID positive?
Well, I think, you know, what we've had is members writing to us, because what happens now is I'm told that the hospital groups have formed ethics committees, regional ethics committees, or ethics committees for particular hospitals, and they will have entrance criteria into those, into their ICU facilities. And the concern is that you have a patient who comes in and for some reason with COVID, and for some reason they don't qualify. Now, to use an example here in the UK, the National Institute of Clinical Excellence put out a set of guidelines a couple of weeks ago, and they use the frailty index, which I think, amongst other things, the South African Critical Care Society also uses. Now, the frailty index won't be for children, but the problem with the frailty index is that it discriminates against people with underlying medical or intellectual disabilities. And the problem there, of course, is that that is a form of discrimination, and that's what one has to be so careful about. But what people are concerned about is when there are ICU beds available, and for some reason someone is, you know, care is withheld because they don't qualify. It might be, probably most commonly would be for reasons of age. You know, South Africa, there could be a whole host of reasons, and we are worried, you know, doctors at the moment and healthcare professionals are the heroes, but we are worried in 5 or 6 or 7 years hence, you are going to become the villains and, you know, be living with the consequences of decisions that you make at the moment.
Thank you, Graham. I think that's where Shamiel comes in with humility, because things are changing all the time.
Absolutely, absolutely.
I've got a last question from Kalavani Naidu, and he asks, in the case of children, does the ICU specialist need parental permission first for withdrawal?
I mean, off the top of my head, you know, if I had to say, if I had to give you a quick fire answer, I would say yes. I think if you look at the HPCSA booklet as well, they say that if you're going to withdraw based on futility, and I think Dana Ballott's article also looks at that, if you're going to withdraw based on, let's say, futility, qualitative or quantitative evaluations of futility, then you should be offering the patient an alternative if you can't do it in your particular unit. And then the other thing that I think that we've got to remember and is the importance of palliative care and palliative care consultants and their role in what's going on at the moment. I mean, it is just so important.
I think you touched on a very important aspect there, and specifically for our children with chronic complex diseases, to have a palliative care advanced care plan in place during these times.
Yeah, absolutely.
Graham, thank you very much for joining us. I think on our chat group, there's some of the links to your MPS webinar posted, so people are welcome to join. Thank you so much for joining.
Thank you for the opportunity. Cheerio.
Bye-bye. Right, we will be moving on to our last speaker, and it gives me great pleasure to welcome Lori Lake from the Child Health Institute at University of Cape Town. And she's going to talk to us about child rights and the family rights, and specifically about the parents' role, and I think lots of questions around parental admission when the child is admitted to a hospital during a COVID infection. So we're just going to put Lori on.
Hi, sorry, just getting up to speed with Zoom and the delights of online engagement. It gives me great pleasure to be part of the SAPA seminar and to be presenting some of the work of the Children's Institute over many years. So we're a policy research institute at the University of Cape Town. And we're really interested in tracking progress towards the realization of children's rights. So we tend to adopt a child-centered view or child and family-centered view when we're assessing laws, policies, and programs for children. So I thought maybe just to begin, it would be helpful to get a clearer understanding of the South African family. And if you take a look at this World Family Map of 2017, what stands out so starkly is the ways in which South Africa is an outlier in terms of parental co-residence. So relatively few children in South Africa living with both parents. And this is a vestige of the migrant labor system. So the only other countries where you see a similar pattern would be countries such as Lesotho or Swaziland, which are also sending workers to the mines. If we look at the current status, we're looking at roughly 1 in 3 children living with both parents, nearly a half of children living with one parent, and most of those living with their mothers. Important to recognize that they're not necessarily living alone with their mothers, that there may be other adults in the household, but that those mothers are carrying a significant burden of care. And then roughly 1 in 5 children living with neither parent, mostly in households headed by a grandparent. And again, important to note that most of those are not orphans, and 85% have a mother living elsewhere. So it's really important to understand that South African families are diverse, they're mobile, they're fluid, they change over time as families attempt to balance their needs for education or employment versus the care and safety of their children. So there are a range of policies and programs such as the Child Support Grant that are designed in a very responsive way in order to follow the child as they move from one caregiver to another. And it's really important to understand both the fluidity but also the diversity of family form in order to understand who children are actually living with and who is responsible on a day-to-day basis for their care and protection. Equally important, we need to appreciate the extent of income inequality in South Africa. If we look at the minimum wage of 3,500 Rand per person per month, then we're looking at roughly 80% of people living below that minimum wage. That's if you were living in a household, a single person household, and you were living off that 3,500 Rand independently. What's of greater concern is the number of children living below the poverty line of 1,183 Rand per month. So we're looking at roughly 60% of children living in incredibly poor households. And we really need to understand this existing context in order to appreciate the impact, not just of COVID-19, but of the lockdown and the economic recession that is to follow. It's also helpful, I thought, to just understand how children are disproportionately affected by poverty. So in this slide, you can see that income, so per capita income coming into an adult-only household is significantly higher than households with children, and that children living with extended families or in lone parent households are extremely vulnerable. The other key concern is that the current safety net, the child support grant, falls below the food poverty line. So it's not sufficient to meet the nutritional needs of a child. So real concerns, particularly as we're starting to look at the impact of lockdown. We've seen basic food prices increase very rapidly, and an average food basket has increased in cost by about 250 Rand in the space of a month. So one of the key concerns is, are children going to be dying of COVID-19, or are they going to be dying as a result of the lockdown and economic recession? It's also important to recognize that we have extremely high rates of violence against children in South Africa. An estimated 42% of children have experienced some form of violence. In most cases, the perpetrator is known and trusted by the child. These perpetrators are not just men. They're also mothers who are struggling to cope, very often with food insecurity and or depression or domestic violence. And that violence against women and children tend to share common risk factors and occur in the same household. And we've seen globally a significant impact, a significant increase in reports of domestic violence, almost tripling in Spain. Similarly, the GBV, gender-based violence helpline in South Africa has seen an increase in calls. And therefore, we're really concerned about the protection of children in a situation where many of them are locked within their households and are unable to access support through schools and or ECD centres. So having had a look at the worlds in which children inhabit, I thought it might be worthwhile just reminding ourselves of parents' responsibilities and rights. So very often as parents, we think about our rights first, but the Children's Act has deliberately phrased this as parental responsibilities and rights, because parents are responsible for the provision of care, the protection of children, maintaining contact, providing guardianship and consent to medical treatment, and obviously contributing to the maintenance of a child. At the same time, we know that in the South African context, many families are struggling to meet children's basic needs, and the state has and continues to play a really important role in supporting children and families through the provision of social services, through the provision of social assistance in the form of the child support grant, and through the provision of healthcare services. So we know that children in South Africa are particularly vulnerable to the impact of COVID-19. Poverty is a concern. Similarly, hunger, poor access to water. 1 in 5 children living in overcrowded households. Very high levels of stunting, which may compromise children's immunity. 1 in 5 children living far from clinics, high levels of child maltreatment, and potentially high levels of children with pre-existing mental health conditions. And we also know that the, in a sense, triple tsunami of COVID-19, lockdown, and economic recession are likely to really intensify those pre-existing inequalities and stresses on both families and children. So what does that mean for our response as a health system? So far, our efforts have focused primarily on prevention and the promotion of hygiene and social distancing. As we start to turn our attention to treatment, it becomes really important for us to safeguard pediatric resources, particularly given that adults have proven to be more vulnerable to serious infection or severe infection elsewhere in the globe. But at the same time, we cannot allow this to decimate resources for pediatric care. It's equally important for us to continue to be protecting and promoting breastfeeding in order to give children the best possible start in life, and to ensure the maintenance of routine services, from vaccination through to contraception, through to access to ARVs and other forms of chronic medication. And then when we admit adult patients, we need to be asking the critical question, where are the children? Are there children left at home? And to recognize that the adult patient in front of us may be the mother, maybe the caregiver, maybe the grandmother of the child in question. And we need to be making sure as a health service that we are putting adequate systems in place to identify children in need of care and protection, and ensuring a smooth referral to social services or to family care. We also need to, wherever possible, minimize separation of children and families. We know that the evidence is really strong that where a family member is present, this improves the child's ability to cope with the fear and distress associated with hospital admission, and that family care helps to improve the prognosis. So we need to be thinking quite carefully about how we manage child patients, and how do we ensure, wherever possible, families to be present or find other ways of enabling children and families to maintain contact. And we need, as health professionals, to provide as much information, reassurance, and psychosocial support as possible, both to adult caregivers who may have to leave their children behind at home, as well as to children who may be separated from their parents. So I'm excited by the work that Michelle Maring is doing with her palliative care team, to start to think through what is the kind of conversation that we need to be having with children and with parents at each step on the journey, from initial concerns around diagnosis through to hospital admission, potentially through to intubation and then recovery, and or grief and loss. So are we putting those systems in place? And where we're thinking about psychosocial support and mental health, are we indeed also thinking about children? And last but not least, we need to be thinking about consent. And how is that going to work, given that in many cases, children who have been severely infected are likely to have caregivers who have also been hospitalized. So who in that case gives consent, and also what happens when children are living with caregivers rather than parents. where only parents and guardians are able to give consent to surgery. Equally important, we need to be looking beyond the healthcare system. We need to be strengthening community-based services and support. As pediatricians and leaders for child health, we need to be thinking a lot more carefully around the response to food security and hunger. We need to be tracking that in our routine services and looking out for that in terms of hospital admissions. And then we also need to be looking out for children in need of care and protection. So given the escalation of violence against women and children under lockdown, again, there needs to be routine questions and a system in place to ensure children can access care and protection. And finally, we need to be looking much more closely at mental health and psychosocial support. So from my side, not necessarily a whole series of answers, but more of an agenda for child health, and really a call for us to consider the needs of children and families, not just their medical needs, but also their needs for food, for protection and psychosocial support. So I think that's it from me.
Thank you, Lori. Can you guys please post questions if you've got any questions for Lori? I'm going to start off with a question I had yesterday from one of my colleagues. Parental rights to visiting their child with COVID infection. What is the right of the parent, and how do we balance it towards safety towards our staff?
I think that's been one of the key challenges is under COVID-19, we're having to weigh up different rights and responsibilities, and different rights against one another, and the interests of healthcare workers versus the interests and rights of patients and their families. So I know in the neonatal guidelines, there's a recommendation to separate sick neonates who are needing admission from their mothers if their mothers are positive. And globally, there's been some different guidelines or guidance around, whose interests hold sway. And I think here what we've done is we've opted to prioritize the safety of our health workers and other infants in the neonatal unit. But that does raise real concerns about the care of very young babies who are separated from the mother. And I know there has been an effort in the pediatric guidelines to promote or to avoid separation of children and families wherever possible. So not necessarily a clear answer or a line in the sand, but I think that gives you a sense that it's a really complex and challenging area, and that these guidelines may shift as we move through the pandemic.
Thank you, Lori. Yes, I think it's very true. We see changes in our guidelines all the time as we learn more about this pandemic. I've got a question here from Isaac Mwimba. Can we bring children for vaccination?
As far as I know, routine services are being maintained. So there is a push to protect routine care. And similarly, I think the other area we need to be looking out for is making sure that all parents are aware of danger signs. Certainly in the conversations I've had with students from around the country, they're sort of talking about facilities being eerily empty and quiet at this time. And I'm concerned that many parents are feeling quite anxious about bringing their children either to the clinic or to the hospital. So I do think there needs to be very clear messaging that encourages parents to seek medical care when necessary.
Thank you, Lori. Michelle Meyering is asking, are there enough plans in place for children who need to be quarantined in SA, especially those who end up being orphaned?
I'm not sure about how much, what kind of accommodation has been put in place in terms of quarantine, and what that looks like across the country. But I think we do need to be thinking about children when planning for quarantine, and again, trying to maintain family units and care arrangements for children as far as is possible. And then I think there is a real concern looking forward around alternative and foster care. So if we're looking at 1 in 5 children living with grandparents, and we know that grandparents are particularly vulnerable to COVID-19, then what plans do we have in place in terms of family or alternative care? And we know here in the Western Cape, or in the city of Cape Town anyway, that we have very limited foster care placements. And I think we do need to be proactively thinking a little bit ahead of the curve in terms of child protection.
Lori, and then there's another question from Kunyanya. Should hospitals be keeping children suspected with COVID, diagnosed with COVID, in similar wards than adults?
I'm not quite sure what the question is asking. So if both the child and, it's very different. Again, it's very difficult, because if you're looking at an adult who is needing to be intubated, you don't necessarily want to have the child in the same room. So I think it is complex, and I'm probably not, as the one doctor, the one person who's not a doctor in the room, I don't think I'm the best person to answer that question. But I think the intent is to try and avoid unnecessary distress and trauma for children by separating them from their caregivers. So it's a call to factor in children's need for psychosocial support when we are planning our response at a local level.
I agree completely that children has got different needs, and I think as long as you can cohort the children, we should rather have them in separate child-friendly areas, specifically to allow their caregivers in. And I just see Alan Davidson has commented that we definitely need to keep going with vaccination, and I think this is a message that we as a pediatric fraternity should put out there, that immunizations should be going on. Otherwise, we're just going to be overwhelmed with all these vaccine preventable diseases.
Yeah, no, I think it's been very interesting. I think because in many ways our response to COVID-19 has been shaped by the pattern of the disease in the global north, where you have a high proportion of elderly people, and the desire to protect the elderly and the adults who are at risk is absolutely appropriate, but at the same time we cannot forget the children. And here in the South African setting, where children are already so vulnerable because of their care arrangements, because of their living conditions, because of the high levels of poverty and violence. We really need to be factoring that into our response and into our routine care, rather than seeing that as an add-on.
Right, I think there's a last question coming through from Hamid. If parents and children are positive and the child has no signs, should we separate the child from the parent?
Again, it would be a question of how severe the parent's illness is. I mean, you're talking at the moment about both parent and child being positive. So again, it would be, I would think, a matter of degree. And again, I would be guided by you and the pediatricians in the room.
I agree with you. I think the parent and the child should stay together unless the parent is extremely unwell and not able to take care for the child. But we want to try and keep it child friendly.
Yeah, and maybe just one last thought that we need to think quite carefully about: how do we prepare children for the situations that they might encounter when being hospitalized? So how do we prepare them to encounter everyone, wearing PPE? How do we ensure that they understand that there's a caring person on the other side of that uniform? Yeah, so to really sort of think through what this might mean, what it would be like to enter a hospital as a child, and to ensure that we are supporting children right the way through that journey.
Okay, I think we've gone through all our questions. Lori, thank you so much for giving us a view on what's happening on the social economic side to children. Very important for us. I'm going to ask your permission if we can share the slides to the SAPA group, and then I will email it. And I think we've just gone over 6, and I think we need to log off. Thank you everybody for joining us tonight. We will be sending out more emails, and hopefully we'll be doing a follow-up SAPA webinar on more COVID topics in 2 weeks' time. There's been a feedback link on the email that we sent out. I would like you guys to go on and please give us some feedback. We want to improve our SAPA content. This is for you guys, and by giving us feedback, we can make it better and tailor it to your needs. Thank you, everybody. Good night.
I'm just going to end up and just say thank you very much from SAPA for everybody's enthusiasm. We haven't had 2 weekly webinars until this recent COVID crisis. So I think it's been a good opportunity to share pediatric views. Thank you, Beira, for putting it all together. And thank you to all the speakers. I think what's come through loud and clear from a SAPA point of view is advocacy for children. And I think that's been our biggest concern. So we've had all kinds of questions like, is it legal to have protocols for children, which is different to, for example, the Critical Care Society or the Adult Renal Society. And I think it's definitely a great opportunity for us to be putting input into all kinds of protocols, whether it is in your own hospital, your own ward, if you work in an adult and children's hospital, if you work in a private practice. From a South African Renal Society, we've put in a South African Pediatric Renal opinion and consensus document, and we're looking at doing the same for ICU. And I'm really grateful to Lori for really putting it out there. I think we're not going to be seeing, hopefully, loads of children dying or very critically ill, but I think advocacy for children and their rights and having their parents with them is vitally important. So thank you very much, everybody. Thanks for putting it all together, and thanks to all the speakers. Most importantly, thanks to 233 of you for joining us. Have a nice evening. Bye-bye.